My name is Katrina and this is my cardioversion Osce. So today we've been dispatched to a 70-year-old male with chief complaint collapse from chest pain. My bystander has gotten all my offside has gotten all my vitals for me. So we've got a heart rate of 170, blood pressure of 70/40, rest rate of 18, BGL 7.6 and temperature of 37. He's got no radials and a rapid carotid pulse. This indicates that he is cardiovascular compromised because his blood pressure is hypotensive and he has no radials and a lowered capillary refill, peripheral capillary refill. So what we're going to do is we're just going to lie him down. I'm going to gather a history from his daughter who's also in the room. So daughter, does your dad have any medical history?
Yes, he had a MI 5 years ago.
An MI 5 years ago, okay. And is he on dialysis or anything like that?
No.
Cool, so that's going to rule out any electrolyte imbalances. Has your dad been well recently? No coughs, colds or flus?
No, he's been fine.
He's been fine? Cool. I'm just going to check the extremities for any signs of cellulitis or anything which could indicate that he has sepsis. So there's no sign of infection. Sweet, so we're going to go ahead and turn on the monitor and put on a 12 lead and a 3 lead, and I've also placed the defib pads in place. So it looks like we're in VF at the moment, so that's a rhythm which we could possibly cardiovert. I'm going to call for backup to get an ICP on the way. So AT1 calls control.
AT1.
Requesting R50 for a status 1 cardioversion.
Roger that.
Cool. So I've placed a large bore IV in place in case we need any sedation, but at this stage is not obeying command, so any sedation which I can give is not indicated. So I'm going to print that out just to double check that that's VF. Sweet, so that is. So what I'm going to do is I'm going to synchronise it. And then I'm going to print it out to make sure there's a detection symbol above every QRS. Which there is. So now I'm going to get my offsider to go through the cardioversion checklist with me.
Place pads in either the apex sternum or anterior-posterior position in addition to the ECG electrodes.
Cool, I have done that.
Ensure the defibrillator is in manual mode.
Yes.
Select the lead with a visible R-way, then ensure that artifact is minimized.
Yep, so I've selected lead 2 and the artifact is minimized.
Select synchronized mode.
I've selected synchronized mode.
Confirm there is a detection symbol above every QRS complex.
Yes, we confirm that in our printout.
Ensure the patient has received adequate sedation if indicated.
Not indicated for this patient.
Select the joules, charge the defibrillator and confirm everyone is clear.
Okay, just before I do that, I've got my airway equipment beside me if needed. So I'm going to charge the defibrillator.
Press and hold the shock button until the shock is delivered.
And everyone's clear. I'm going to shocking, shock delivered.
Determine the rhythm and the level of cardiovascular compromise.
So my patient's still in VF, still has no peripheral pulses, and the carotid pulse is still rapid, and the capillary refill is 4 seconds, so he's still in severe cardiovascular compromise.
If administering a second cardioversion, confirm the defibrillator is still in synchronized mode.
Still in synchronized mode. I'll print it out to make sure it's still. Yep, so now I'm going to charge again. And I'm going to shock again. Clear, shock delivered. So we're now in normal sinus rhythm, checking the airway is still patent, breathing is still adequate. Sweet. And he's got a weak radial pulse. So my name's Katrina, this is my RSI video Osce. So we've been dispatched to a 40-year-old male who's fallen from the roof and the neighbours called us On assessment of the patient, we've discovered that the patient has a boggy patch of 6 centimetres on their occipital, so we're suspecting a severe basal skull fracture, or TBI. The heart rate is 50, blood pressure is 160/90, rest rate is 12 and irregular, VGL is 7.6 and the temperature is 37. We've called for a backup RSI officer. They're 10 minutes away. The RSI officer has requested that we complete the RSI prep list, so we'll do that as well as treating the TBI. Okay, so to treat the TBI, we've got 10 litres of oxygen running through a non-rebreather mask. We've got bilateral IVs in each arm with fluids running into the left arm. We've immobilised the spine by placing towels either side of the patient's head and positioning them in a way that they are able to maintain their airway. So we've put a nasal prong on for the RSI. We've got all our cables connected, the 3 lead, the 12 lead. We've got capnography ready to place on for the RSI, and we've got the blood pressure cuff and the SpO2 monitor. I've placed the Thomas tube holder under his head, and we have our bag valve mask and other airway adjuncts beside the head in case of anything. I'm going to put the suction to the left of the patient's head, leaving the right clear for the airway gear, and I'm just going to tuck the suction under the arm, and we're going to test that it's working, which it is. Okay, so now to run through my RSI checklist. Attach nasal prongs without oxygen. We've got them attached without the oxygen. Pre-oxygenate using a reservoir mask at 10 litres or a manual ventilation bag at 10 to 15 litres. So we've got that running. Attach ECG, NIBP and SpO2. Prepare capnography if this is available. Position the monitor so that it can be seen, leaving space to the right of the patient's head for intubation equipment. Gain IV access, preferably in 2 sites, so we've got it in both arms. Prepare a running line of 0.9 sodium chloride, so we've got that and we've drug checked it. Position the patient for optimal airway control. For example, consider placing a folded towel under the head. So we've got a towel under the head to place the patient in the sniffing position. Place an ET tube holder under with the strap undone under the patient's head, so we've got that ready for when the RSI tube is in place. Ensure suction is working and turn it off, so we've done that. Prepare a manual ventilation bag with PEEP valve attached and at 5 centimetres, so we've done that. Obtain a full set of vitals, so I've got all the vitals on my screen over there for when the RSI officer arrives. If possible, update the responding ICP with the patient's condition and vital signs. Prepare the area. If the patient is not in an ambulance, clear the area so that there is access to both sides of the patient if possible. So we've got the legs fairly clear and the right side clear for the airway equipment. If the patient is in an ambulance, clear away as much unnecessary equipment as possible, which is not applicable in this situation.